this week. So this will be going onto YouTube, onto our YouTube channel, which actually has 17 subscribers, which is pretty good. So if you want to watch this back later, or you want to pass on to any friends, then I'll try and upload it to YouTube, and you can watch it there. Admittedly, you might not want to sit through the whole hour and a half again, but you never know. So if you do, then it will be up there tomorrow. Anyway, so let's get started. So my name's John. I'm on an academic F2 at Salford. I did a talk before Christmas on the acute abdomen, and this is my second Twilight Teaching Salford session. And I'm going to be doing possibly a slightly tricky topic for third year revision, the kidneys, not necessarily the favourite of many medical students, and I certainly did not enjoy learning about the kidneys at medical school, so well done for turning up to this session. But I'm going to make it as interesting as possible, and I will say that the kidneys are, as you kind of progress through, they become more interesting, at least to me, as you find out more and you see patients with problems related to kidneys. So I think this session will hopefully give you a bit of a sort of clinical overview about a few things to do with the kidneys. So I'm not going to be covering chronic kidney disease. I'm just say that now because I can't possibly cover in an hour and a half, which is all this session is going to be, chronic kidney disease and AKI as well. So I'm just going to be covering AKI, and I'm just going to also talk about a few renal investigations that we do routinely in hospital, and you'll certainly see when you're in hospital placement, and also will come up in your OSCEs and are an absolute classic in sort of written exams, progress tests, that kind of thing. So, and then I'll cover a couple of common conditions, and we'll go through a few questions, sort of, or exam question type things at the end if we have time. But obviously, if you've got any questions at any point, please just put them in the chat. I've got the chat up next to me on my other monitor, so I can see the chat. So if you do have any questions, just let me know, and I'll answer them as we go along. So another thing to mention, I'm just talking about adults. So pediatric renal problems and pediatric renal physiology, I'm not going to cover. I mean, as a medical student, I wouldn't worry too much about the pediatric renal stuff, but that is just a caveat really to what I'm saying. So I know kidneys sort of elicit a pretty, well, to most medical students anyway, a pretty unpleasant response because they sort of associated with so much information. And to be honest, I don't think I really understood, even as starting as an F1 doctor, I really understood what the kidneys did and how they worked. So I don't think it's unreasonable for to feel a bit daunted by this session. So I'm just going to be sort of focusing on the basics. So that's going to be, as I've said, essentially the basics of AKI and the basic functions of a kidney, which you kind of have to know in order to understand what an AKI really involves. So I'll cover that first, try and make it as interesting and interactive as possible. If you've got a phone, as I said at the beginning, please use the phone to interact, and I'll show you how in a second. Then I'll cover quickly what causes an AKI and how you can apply that to sort of exam situations, which is, I'm assuming, why you're turning up on a Wednesday evening to listen to me talk. It's because you want to do well in your exams, and by being here, you probably inherently do well in exams because this is obviously outside of your normal working hours. How to interpret a UNEs. I say that because it's just sometimes understanding when someone says they've got a high creatinine or a high urea or a, try and interpret renal function tests, then I think, if you can have a basic understanding of that, you're set really as a medical student. You don't need to know loads and loads of detail. But and then I'm going to briefly cover, or very briefly cover, what we mean when we say IV fluids, because I feel like it gets thrown around a lot, the term like IV fluids and fluid boluses, but I think just understanding roughly what anyone's talking about when they say fluids is pretty helpful, especially when talking about the kidneys. And just a disclaimer, so if you're watching this back, or you're watching this on YouTube, or you're watching this to revise from, remember, this is just revision. This is not meant to comprehensively cover everything to do with the kidneys, so please don't think that I'm covering everything and that I've not missed stuff off, because I will have missed stuff off, just the nature of revision. But anyway, so over to you. So I appreciate that not everyone may have access to a phone, but you should be able to, if I activate the, let me just do this. Bear with me 2 seconds. Let me see if I can share my screen to. Of course, it's not working now. Sorry about this, I'll be 2 seconds. I'll load it up. There we go. So if I share, can you guys see that? If you can see that, great. Can you log onto there and tell me what the kidneys actually do? If you can't get it to work, let me know in the chat. It worked last time? Anyone got any? Oh, blood? Filter blood. I think that's probably what someone was trying to say. Blood pressure, there we go. Yeah, regulate blood pressure. Yeah. So the word filter has been used a few times. Maybe it's a bit slow, so we'll just give it a second. Just intrigued to see what people are. Urine, yeah, good. Erythropoietin, very good. Not something that I'm going to talk about today, but that's certainly something that the kidneys do, is produce erythropoietin. Hydroxylation, yeah, vitamins, yeah. So I think that does actually very nicely, if I was to screenshot that, sort of represent what the kidneys do, and you probably have described the next few slides quite well. So hormones, filter, blood pressure, electrolytes, regulation. I think regulate is a word that should come up a lot with the kidneys. So that's good. I will quickly switch back to PowerPoint. Let's see if it work. So moving on. So the kidneys, this is a sort of diagram of a nephron. Admittedly, probably a bit too much going on in this diagram. I do apologize for that. But essentially, what I'm trying to show here is the whole nephron. So this is the working part of the kidney, if you like, where all the filtration and things happens. So I've just illustrated there with the arrows, the blood flow into the glomerulus. So if you're not familiar with the anatomy of the kidney, what you're looking at there is the glomerulus circled there. And that's where blood that comes, arterial blood that comes through the aorta and the renal arteries eventually reaches the glomerulus and is filtered through the basement membrane in the glomerulus. And then what's filtered runs through the nephron all the way eventually into collecting ducts and out into the renal pelvis and then into the urine. So as you can see from this diagram, someone else wanted to join with me. As you can see from this diagram, lots of things are getting filtered in and out, and that is partly what makes the kidney so confusing, I think, for people, is that there's so much going on. So I'll try and simplify it as much as I can. So there's 2 to 3 million nephrons in your body. If you've got a functioning kidneys, then you've got 2 to 3 million nephrons. which, you know, is quite astounding when you think about it. So there's a lot of filtration happening every single second, every single minute in your bodies, and thankfully that's why, you know, you're able to maintain some sort of homeostasis. So what do the kidneys actually do? So water electrolyte regulation, you've mentioned it on your previous slide, when I asked you what they did. So water electrolyte regulation is obviously one of the key aspects of kidney function. So water regulation, essentially how much water you're getting rid of, and how much water you're keeping in your body. And without that function, then either you become extremely dehydrated, you lose all your water, or you become extremely overloaded because you're not getting rid of any water. So the kidneys essentially keep you alive in that respect. Electrolyte regulation, so they regulate most electrolytes. The perhaps most notable ones for especially tonight, but also, you know, for medical student purposes, are potassium and sodium. And potassium particularly is a problematic one if you don't regulate it well. So the kidneys regulate potassium and sodium and all the other electrolytes as well. Excretion, so that's a key one. Excretion, essentially, by that I mean excreting toxins, drugs, urea, all the sort of waste products. If you think about how you could get rid of things from your body that you don't want, peeing them out is one of the main ways. So that's an extremely important thing the kidneys do. Blood pressure regulation, someone already mentioned renin, and that's a key part of what the kidneys do, and I'll come back to that in a second. So blood pressure regulation is something that you can be forgotten, but the kidneys are vital in that. And another one that is perhaps less well thought less of is acid-base regulation, but the kidneys play a key role in acid-base regulation. So definitely don't forget that one. So as I said, filtration of electrolytes and water, and then they effectively reabsorb through different transporters water and electrolytes. So they push it all out into the filtrate, the urine, and then over the course of its progression through the nephron, they slowly reabsorb the electrolytes. The kidneys make urine. I know it seems like a little bit of a simple statement, but one that actually is very easy to forget, and I'll come on to it later, but it's really important that you don't forget that the kidneys make urine, because when patients don't wee and they don't pass urine, there's obviously a problem somewhere, either in the kidneys or downstream of the kidneys. And actually one of the few things that you can assess in a patient without having to do anything other than, you know, look and ask the patient is whether or not they're passing urine. And in that urine, you're passing urea, which we'll come on to in a bit, but also drugs, metabolites of drugs. So kidneys are vital for drug metabolism. So if your kidneys aren't working, then how are you going to excrete drugs? Blood pressure regulation, I've talked about briefly then with renin, but I'm not going to talk about the renin-aldosterone angiotensin system because it's very complicated, and I don't want to sort of briefly brush over it, but it's worth looking up in your own time. If you're not familiar with it, it'd be worth just having a look at that, because it's a common exam question, and one that doesn't actually take that long to understand, but will really help you understand both drugs like ACE inhibitors, but also the whole physiology of blood pressure, which as you go later on in med school and as you're a doctor becomes more and more relevant, I think. And then acid base. So kidneys reabsorb bicarbonate. I will talk about acid base at the end briefly, but bicarbonate is essentially reabsorbed into the blood in the kidneys. So in order to maintain acid base, you need bicarbonate in your blood and you need acid H+ in your blood. So the kidneys sort of do both. They monitor both and they regulate both of those. So that's extremely important. And then three other things, which actually I think you've all mentioned. So hormone secretion, gluconeogenesis, which I'm not going to talk about tonight, but that's another function the kidneys do actually get involved in. And then metabolism. So I think someone mentioned vitamin D, and there's various other things that the kidney does, but hormone secretion, so erythropoietin, amongst others. And essentially what I'm trying to say with those is it's vital to homeostatic regulation that your kidneys work. So when your kidneys don't work, what happens? Well, if we think about all those things I've just talked about, if your kidneys aren't working, you can't excrete and you can't reabsorb. So your fluid overload occurs where you're not able to excrete the water. You're not able to get rid of the water you need because the water's not being filtered out. So you become fluid overloaded. And you get deranged electrolytes because your electrolytes are not being regulated properly. So very simply, that's what happens when that aspect goes wrong. You can't produce urine, fine. So you can't produce urine. And so what happens when you get a buildup of toxins in your blood because you're not peeing them out. They're not being excreted out of the kidney. Basic sort of principle, if you like, but actually it's one of the main reasons patients with AKI and CKD become unwell is they've got these sort of toxins building up. Blood pressure dysfunction. Now, I'm not going to talk about that because that usually takes a while. That's more of a CKD problem, but certainly blood pressure is an issue in patients with chronic kidney disease. If you've done any kidney or renal placements, you'll have seen these patients who have blood pressure problems, but I'm not going to talk about that tonight. And then acid-base regulation. So more acid in the blood. If you are able to excrete acid or you're not able to resorb bicarbonate, you end up with a more acidic blood, which is called acidemia or an acidosis. So that's basically what happens if that goes wrong. So hopefully that gives you an overview. So there's two ways, if you like, that the kidneys can go wrong. Try to demonstrate them here. So over time, you've got the graph. You won't be able to see my mouse, but essentially you can see the graph on the left showing CKD. So it's a gradual decline, sometimes characterized by sudden drops, but usually it's a gradual decline that occurs over, if the time at the bottom here would be years. Now, I'm not going to talk about CKD. I'm just going to talk about AKI because I can't possibly cover both in an hour and a half. So with renal dysfunction, AKI, you get this sudden drop off. So your renal function is absolutely fine, or is at a baseline is probably that way of describing it. And then suddenly it drops off, it becomes worse. And then usually it recovers, although not always. And that's obviously something to remember, is AKI can actually result in lack of recovery. But for simple purposes, we'll just talk about this bit, which is what happens when it drops off. And that is an AKI, the dropping of renal function in a sudden period of time. So I'm going to ask you guys, what does AKI mean? So if I share my screen, I want you to tell me, can you see that? Hopefully you can. What does AKI, if you're on the thing already, you should just be able to skip to the next video. Acute kidney injury, that's correct, but what does it, I should have probably specified more. What does AKI mean to you? Yeah, so creatinine injury. So I think someone said 50%. I think it splits it up here, which is probably, I have to probably change that. There we go. Yeah, so that's good. So we'll talk about the definitions, but yes, certainly that is one of the definitions. Yeah, exactly. That's what I'm going to talk about next, so that's very good. So I think you've actually covered those 2 points there. Hyperperfusion, that is indeed one of the causes, and we'll talk about that more. So you've talked about urine output and serum creatinine there. Those are the key things that I'm going to mention in the next few slides. So that's good that you're kind of obviously already aware, which makes, obviously this is revision, but usually response to IV fluids, that's potentially correct, but I'm hopefully going to at least introduce a bit more nuance into this talk just for the purpose of exams. But in real life, unfortunately, well, not unfortunately, but they do tend to just respond to IV fluids, but there is more to it than just fluids. Hyperkalemia, yeah, so very common in AKI. Protein creatinine ratio high, hypovolemia. Yeah, so the protein creatinine ratio and the albumin creatinine ratio, I'm not actually talking about particularly in this session because it's more CKD, but you certainly you do get that in renal dysfunction. Hyponatremia, pre-renal renal. There we go. So I think if you took all of this, I don't know if you can see me flicking through there, but that basically summarizes the next 10 slides. So let's go through that in a bit more detail. Let me just switch back to that. So hopefully you can now see that. So what does it mean? How do we assess if the kidneys are actually working? Well, the easiest way to assess, so there's lots of ways you can assess, and you've actually talked about them all there, so very good. The easiest way to assess and the best way of thinking about AKIs when you're like, trying to work out if someone's got one, is how well are they excreting? And so how well are they excreting waste products? How well are they excreting urine? So from that, two things: how much urine are the kidneys able to produce, and how much waste products are still in the blood. Those are the most simple ways in which we can assess if someone's got an AKI. So don't worry about any other things for AKI than those two things, and you won't go much wrong, really. So the KDIGO criteria, you may have heard these in lectures, and I don't want to bore you with the details of the KDIGO definitions. If you want to go and read the document that they produced, which is, I think, their international kidney disease organization, so that, the worldwide definition of AKI basically is this. Now, that's a lot of words, and it seems a little bit hard to sort of process if you just read that once. But what it's trying to say is SCR is serum creatinine. So a rise of over 26.5, so the other units is American, so ignore those, but 26.5 within 48 hours. So a creatinine rise, okay? A creatinine rise over 1.5 times the baseline. So someone already has said 50%, which is, the same thing. So 1.5 times the baseline, which is presumed or known to occur in 7 days. So an acute rise, or even urine output of less than 0.5 mils per kilogram per hour for 6 hours. Okay, so that's the international definition. That's the one that, in exams you'd be asked about, or in OSCEs, or on the wards, if someone was asking you what is an AKI. And the two things I want to highlight from that definition, which are really important to appreciate, bear with me 2 seconds. Just checking it's still recording. So sorry, the two things you just need to appreciate there are that within 48 hours, okay, so it's an acute rise. And sometimes it's easy to think that high creatinine, if you see someone with a high creatinine on the wards, you see a blood test in an exam, you see a blood test in an OSCE, you assume that they've got an AKI because their creatinine is high, right? But what happens if they've got CKD and that's their normal, that's their baseline? So an AKI is when it's changed from that baseline acutely. It's a simple concept, but one that, you can easily forget, and you actually do need to see a baseline in order to accurately say that they've got an AKI. Although admittedly, you're not always going to have that information, but someone with CKD will have a high creatinine. That doesn't mean they've got an AKI. So the definitions include 3 sort of stages, which you will see if you're at Salford on placement, which presumably all of you are. If you're not, then other hospitals probably do as well. But it will come up with alerts about which AKI stage you are, or what stage of AKI the patient is. So you can, as your AKI gets worse, you have certain sort of creatinine rises that sort of correlate to that. And the thing that I'm trying to highlight with this rather, overloaded graph is AKI is bad. So that graph on the right is basically showing that the worse your AKI, the worse your survival is at hospital discharge. And if you have any sort of AKI, you have a worse prognosis. Now, obviously, that's complicated, and there's, it's not just the AKI that's causing that. Patients who are sick automatically more likely to have an AKI. So, but take away one thing from that slide, and AKI is bad. Okay, if you see it in patients, that they're unwell. So how can you classify it? Well, I think you've already sort of talked about this a bit, and I appreciate the people who've contributed to that, because you've already mentioned that it's pre-renal. So simply for this sort of revision, it's reduced flow to the kidney, reduced blood flow to the kidney. So therefore they're filtering less, right? So there's less blood, there's less filtering, and the kidneys actually get less blood to actually function. So that usually is through hypovolemia, so there's less blood actually circulating, hypotension, so the blood doesn't actually get enough pressure to reach there, and vasodilation, which means that the blood vessels are all dilated, they're all baggy, and so there's not as much blood being pushed through. So if you, three sort of concepts about flow of blood, and they all contribute to pre-renal. All right, so that's kind of something to think about. Intrinsic is basically damage to the kidney itself. Any structure in the kidney that gets damaged can lead to an AKI. So the nephrons, the interstitium, the collecting ducts, the glomerulus, and that's why intrinsic AKI is the one that, well, at least is most scary to me in terms of understanding, because there's so many causes and it's actually quite complicated to understand. Whereas pre-renal and post-renal are lovely. They're very straightforward. You can easily understand the concepts that behind it and know the causes. And that's just skip through there. Post-renal, very simply, urine can't escape the kidney. All right, that's all there really is to it. Why it can't escape the kidney, well, that's different causes, and we'll come on to that. But post-renal obstructive is backwards pressure that causes damage to the kidney because it can't escape the blood. The filtration and the urine cannot escape the kidney. So anyone want to suggest some pre-renal causes? Let me just share my screen again. You can go on to, if you bear with me 2 seconds. Oh, it was meant to be slicker than this, I will admit. So pre-renal causes of AKI. So I want you to give me some, you can give me some hypertension, dehydration, obviously a popular one, sepsis, yeah. Hypovolemia, yeah. Cardiogenic shock, that's a very, very good one that I hadn't really talked about in my thing, but it's very, very true. Rhabdomyolysis. So talk about rhabdomyolysis because it actually is more of an intrinsic cause of AKI, but it's definitely a cause of AKI. I'm kind of putting you on the spot there, and the whole point of you coming to this talk, I guess, is that you learn the pre-renal causes, but you do have most of the common ones there. There's one, renovascular, excellent. That's a very good one. And one that sort of runs on from that, which I'll talk about in a second, if anyone wants to go a bit outside the box before I close the thing now. But right, let me go back to my PowerPoint. So, someone's put another one there. PVD, peripheral vascular disease. Yes, so that kind of renovascular peripheral vascular disease, very good. And I don't actually talk about that much, but certainly it's a very good one. So hopefully you're seeing PowerPoint now. So pre-renal is probably the most common you'd see on the wards. If you walk onto the wards, which obviously hopefully you will do at some point, you will see patients who have an AKI on the wards. The most common cause will be pre-renal, just by definition of the causes of pre-renal being things that you see all the time. So sepsis, just everyone with sepsis seems to get a little bit of a pre-renal AKI at least, if not, a significant one. Hypovolemia from things like bleeding, but also dehydration. Most patients who actually present to hospital who have, are unwell will be at least a little bit dehydrated because they're unwell and they're not able to take in oral intake at home. Diarrhea and vomiting, especially in young people, you can see quite significant AKI. If you've ever had DNV or you've had food poisoning, you probably did have a bit of an AKI just by inherently losing that much fluid in a short space of time. One thing that nobody mentioned on the thing, but is a pre-renal, is an NSAID or ACE inhibitor induced AKI. So they cause sort of afferent constriction. So the blood vessels that supply the nephrons can be constricted at either end, the afferent or the efferent. So efferent, I always remembered it as F off. So efferent going off, an afferent arriving, so afferent blood vessels constricting, will cause a lack of blood flow to the kidney. So NSAIDs and ACE inhibitors both and ARBs cause a constriction in the afferent arterioles. So they cause a pre-renal AKI. Renal artery stenosis and renal fibromuscular dysplasia, all those kind of renovascular causes, which I won't really mention, but they do talk about in exams occasionally, and it's probably worth having a look at, in your own time, just the basics of renal artery stenosis and what it is. Let me flip to the next slide. Intrinsic causes are more interesting. I'll be honest, they are more interesting, but they are more complicated. And I think it's okay to not know much about them as medical students, but to get, basic understanding and maybe understand the basic few that come up in exams. So glomerulonephritis, there's many causes of glomerulonephritis. I won't be talking about all of them today, but I'll cover a couple of them. Vasculitis, acute tubular necrosis, so ATN, usually caused by drugs, especially in exams and OSCEs. If it was to come up, it would be a drug more than likely. And acute interstitial nephritis, which is similar, but is also often caused by drugs. So that's irritating the interstitium in acute interstitial nephritis, and acute tubular necrosis is affecting the tubules. Kind of in the name, use the name to remember what's actually happening. And then obstructive, as I said, anything that causes blockages, so urinary retention and all the reasons why you get into urinary retention, so physical blockages like the prostate in men, to neurological causes like MS or having a spinal injury. Tumors, bladder tumors, renal tumors can cause blockages, and that causes a post-renal or an obstructive AKI. And then stones are a not uncommon cause of an obstructive AKI. So anyway, I'm going to try and, I've got about 5 minutes and then we'll take a quick break. I apologize, I'm going a little bit quickly. I'm going to come on to a case shortly, so hopefully that will liven things up after the break. But for obstructive causes, I just want to mention, so if you see that red line on the screen there, if you have an obstruction there, your other kidney is able to work fine. So your other kidney is able to run through from the kidney all the way down through the bladder, and this is a man, but in a woman it's the same, and excrete the urine without issue. So it'd be pretty unlikely. You'd have to get a pretty good going blockage that's kind of going on for a while to have any sort of change in your renal function on the blood tests, because your other kidney's working fine, even if there's a blockage there, because one kidney working well, it's fine, your body can cope. But if you have a blockage there, this is an obstructive AKI, if your prostate blocks the urethra, both kidneys are blocked. So you're much more likely to see an AKI in patients who've got an obstruction there. And that's certainly, in my experience, working as a doctor, you do see patients come in with pretty awful AKIs just because they haven't peed in like 2 days because they can't get the wee out. And it responds immediately to relieving that. So this is probably not the most exciting slide, but one that actually I don't think really necessarily fully understand unless you read up about it, because just knowing what a creatinine urea is really helps to understand both the blood test you're looking at, but also what an AKI actually means. So creatinine is a product of muscle breakdown. So creatine kinase breaks down to creatinine, and it's released at a constant rate from muscles. So it's pretty steady, it's always being released, and you will be releasing it now at a constant rate. If you exercise, admittedly, you'll probably release more, but it's usually released at a constant rate. And then it's excreted conveniently by the kidneys, completely unchanged. It leaves the body in the same form. So urea is a bit different to that. Urea is a product of protein breakdown, okay? And it's filtered into urine like creatinine is, but then it's reabsorbed in the kidney and then secreted again. So it goes through this sort of pathway where it's coming and going throughout the kidney, which means that the body can use it to allow water to be reabsorbed in the kidney. So your kidney basically takes the urea, puts it into the interstitium, and then the water goes, okay, fine, I'm going to follow. So your urine becomes much more concentrated because the water's been taken out by following the urea. So that's why urea is actually really useful to the kidney in keeping, water reabsorption at the right level. That also means that it's not doing the same thing as creatinine. So it's filtered and then it's reabsorbed, whereas creatinine is filtered and then it's not reabsorbed. It just goes, it just leaves through the urine. So that means that urea is a much more changeable sort of value, if you like, because the serum urea is dependent on how much your kidney is actually reabsorbing. So creatinine arises if the kidney stops working. The serum creatinine rises as your filtration worsens, okay? So that's why it's used in the AKI definition. It's very straightforward. As your kidney stops working, it doesn't filter creatinine, so the blood creatinine increases. Whereas urea is much more variable on the cause of the AKI. So if someone's really dehydrated, because the kidney is trying to hold on to water, it's trying to keep the water in the body, it will reabsorb more urea. So it's really trying to hold on to urea as well in order to keep that water. So if someone's dehydrated, their urea is actually going to be much higher than you'd expect. So that's why you might hear consultants or doctors talking about a really high urea. And one of the reasons is someone's dehydrated. So if you're really, really thirsty, really dehydrated, your urea will be likely much higher than if it was an intrinsic or an obstructive AKI. So that's just something to sort of bear in mind when you look at a blood test and you're trying to work out what's causing the AKI. So halfway through, we've covered why we need the kidneys, why they're important, and what happens if they stop working. We've also covered the way in which people can actually develop an AKI, or the reasons why people have an AKI. So how do we actually find out what type of AKI the patient has? How do we actually establish what I've just talked about? And how do we resolve, or how do we treat the AKI? And admittedly, giving fluids, as someone's already mentioned, is a common treatment, but it's not the only one, and I'll cover them briefly. But I want to present a scenario. So Mr. N, the 55-year-old man. So you're a third-year medical student, you're going with one of the F2s to see a patient in A&E who presents generally unwell, a very common presentation. Generally fit and well normally, but it's just generally unwell. That's all you know before you go see them. Unfortunately, that is sometimes all you know. But luckily, the A&E team have very kindly done a set of observations and they've done some bloods. So before you go see them, you actually have this information to hand. Okay. So I'm going to time for a 5-minute break. Okay. Leave those up. I'm going to give you 5 minutes before I come back. If you've got any questions in the meantime, please just put it in the chat because I will answer them during the break. But take 5 minutes to get a glass of water, or if you're doing something else, then take 5 minutes. And then we'll come back and talk about this case. And I've got a couple more slides to talk about. You can contribute your ideas as well. All right. If anyone's got any questions, then feel free to ask them. So we'll get started again in a minute, but if anyone has got any thoughts on this case, anything they're thinking from just these blood tests and the observations, admittedly that is not how you assess a patient. Obviously you need to take a history, but any thoughts about what might be going on, then feel free to put it in the chat and I will discuss it. UTI causing an AKI. Very good. So that's definitely a differential that I'd have in my mind if I was just presented with what you can see on this slide, because he's got a bit of a temperature, got a bit of a low blood pressure, a bit of a high heart rate, and he has, well, I'll mention it in a minute, but he doesn't necessarily have an AKI because you don't actually know what his baseline blood tests are, but you certainly think he probably does have an AKI. So sepsis with an AKI, yeah, definitely one to consider. Probably the main differential I have going to see this patient. I think the other one would be COVID, just that, you know, the temperature plus the high heart rate, low blood pressure plus the AKI would lean towards sepsis. Yeah, urosepsis. I think that would be the most likely differential. But if anyone wants to throw out any others that they can think of, or any other possible causes for what you presented here. Anyway, I'm conscious of time and no one wants a teaching session that runs over. So I will do my best to crack on, I think. So you should be able to all see the screen. I can still see the chat, so if anyone does have anything they want to say, please just put it in the chat. So anyway, we've got this. I've just been through it briefly, but you know, high heart rate, low blood pressure, bit of a temperature, and then a raised CRP, a raised white cells, so an inflammatory response as well. And then obviously the thing that we're actually interested in this session is the creatinine is 206, which is high, and the urea is 15, also high. You can calculate a urea to creatinine ratio to work out whether or not you think this patient's really dehydrated, but I'm not going to talk about that now because that's definitely beyond third year and not something that we need to sort of worry about. So I'm just going to share my screen again, and we're going into what things you want to do next. Let me just share. So you should be able to see that. So I wanted to know what you wanted to investigate the patient next. Think about the kidney function. So urine dipstick, excellent. Urine dipstick, I will talk about shortly. Chest X-ray, excellent, definitely. UNEs, well, you've had the UNEs already, but I would definitely repeat them. Fluids, volume assessment, yep. EGFR, yeah, I mean, the EGFR, I haven't actually put it on there, would be on, it's Salford anyway, would be in the blood tests, the creatinine and the urea, but you can certainly get EGFR off the system. Fluid volume assessment is definitely one that I'm going to talk about briefly, but yes, please definitely assess that in a patient with an AKI. Measure urine output, very good. Pelvic ultrasound, yep. Well, I will talk about it shortly, but you may or may not need to do that. But unless if you're referring to a bladder scan, then yes. But CRP, or there was a CRP on the previous blood results, which was 157 from memory. So pretty good going, CRP. Renal artery Doppler. Yeah, I mean, we're getting a bit advanced for, I guess I didn't really specify, but what would you want to do next? I meant in A&E and in EAU if you're at Salford. Blood cultures, yes, good, very good. All right, there are a few others and I will mention them, but you've done very well there. You've covered the basics. And I think that's the most important thing. Chest X-ray, UNEs, urine dipstick, fluid volume assessment, urine output, blood cultures, MSU, basics, but especially in your OSCEs, those are the kind of things they're looking for. So yeah, very good. Right, let me switch to the PowerPoint and let's get on with talking about what we want to do next. So that should. So full history and examination. No one actually said that, but I guess I kind of implied that we'd already done that. But a full history and examination, a urine dipstick, a blood gas, a bladder scan, and then establishing the diagnosis, which I guess you kind of already said when you said blood culture and chest X-ray. So that's kind of what I was going at there. So your full history and examination, do not underestimate the value of a full history and examination. You can get the diagnosis of this gentleman and most patients from taking a full history and examining the patient. And obviously that's why you're doing your OSCEs and that's what you do when you're in hospital as well. So his history, he's got a cough, producing green sputum. He feels a bit feverish, doesn't feel great. Otherwise, the history is pretty boring. There's nothing else much in there. He's got hypertension and he's fit and well normally. All right, so good students will ask about, so they've presented with this information. They know he's got deranged creatinine, and doctors as well would ask about fluid intake and urinary symptoms. So fluid, sort of how much you're drinking, how much you're peeing. Urinary symptoms, you got any burning or stinging, any problems passing water, when was the last time you actually went to pass water, those kind of questions. Though, you're showing to the examiner in an exam or to the assessor in clinical practice that you're thinking about what's actually going on with this patient, which is he's got an AKI, or we assume he's got an AKI, and he's also got an infection. So you're kind of thinking about the causes and trying to get to the next level there. Medications, never, especially, well, in any patient ask about medications, but when you think about an AKI, you really need to go through the medications because sometimes they don't tell you about a medication they're taking, and it can be causing the AKI. Any previous kidney problems, because if he tells you that he's got CKD and he's on dialysis, then obviously that changes things. Examine the patient. Crackles at the right base when you listen to his chest. His abdomen's a bit tender, but it's soft. Okay. observations as I presented to you. So he's got a bit of temperature and his low blood pressure and things, but he doesn't look too bad. Good students and doctors will assess the fluid status. So someone's already talked about that, which is very good. So assess the fluid status. So how do you do that? Well, if anyone wants to suggest any other ways of assessing fluid status, but I would say things like looking in the mouth, seeing if their tongue is dry, the mucous membranes are dry, looking to see whether they look dehydrated, so their skin looks a bit if you see dehydrated patients, they sort of look a bit like a raisin. They look dried out, their lips look a bit cracked, they just look thirsty. That's a very good way of assessing whether someone's dehydrated, to be honest. The other ways, look at the JVP. If that's really elevated, that suggests fluid overload. Kind of comes back to the cardiovascular exam, but it applies here as well. Look at the legs. Are they really puffy? Are they full of fluid? Suggest obviously they're overloaded. They've got too much fluid. Blood pressure and heart rate. If their blood pressure is really low and their heart rate's high, that suggests, it doesn't obviously other causes, but it suggests that they potentially are dehydrated, they lack fluid. And then also the other thing to examine is the flanks. So feel for the kidneys, actually examine the kidneys, which you don't always do, obviously, when you're seeing other patients, but really have a look, feel for the kidneys, any tenderness, and press suprapubically, which seems, you do that in the abdominal exam, press the bladder, see if the bladder's full of fluid, full of urine. If the bladder's full of urine, that might well be the cause of his AKI and why he's feeling so rubbish. And the other thing, check the notes for the baseline renal function. So for the purposes of this man had normal renal function when he went to his GP 6 months ago. So his baseline renal function was normal. So he's got an AKI. Once you know the baseline, you know for a fact he's got an AKI. Okay, so next. Remember that from the beginning, the KDIGO criteria? Well, someone's already said it, but it's the patient weeing. Are they actually passing water? Ask the patient, are you passing water? And if they've not passed water in 2 days, then you're pretty sure they've got a good going AKI here, because you look at the definition. They've got a pretty bad AKI. But certainly ask the patient that, and in the exams, ask the patient that, and when you're doing OSCEs, that's the good question to ask patients. And at this point, ask them to pass water into cups from now on, or whatever these are called, I can't remember what they're called, or a catheter. Put a catheter in if he's not able to do that, which a lot of patients aren't if they're unwell and they feel really awful. So you need to measure how much they're actually peeing. So the kidney's not working, they're not making urine, they're struggling to make urine. Admittedly, if they've got a little bit of an AKI, they're a bit dehydrated, they will still pass good amounts of urine. But if they've got a really bad AKI, then they will struggle to make urine. And you've got to ask yourself, where's that fluid going if it's not getting peed out? And the answer is usually into the body, into the spaces around the legs, into the chest, pulmonary edema. And those are not places you want fluid. So think about where it's going if they're not peeing out. So urine dipstick is next. Someone's already mentioned this. It's a very easy, a very quick thing to do, and it provides a lot of information. Now, one caveat, and I'll mention it now, is in old patients. So if you've done a geriatrics placement, then they'll already drum this into you. But if you haven't, then this is something to remember when you're on geriatrics: is don't dip elderly patients' urine to look for infection. So in normal, young, healthy patients, a urine dipstick can tell you whether you've got an infection. So if you dipped my urine and it had leukocytes and nitrites, you'd be pretty sure I've got a UTI. But in elderly patients, that's not the case. So don't do that, because the geriatricians really don't like it. So that's just a tip for when you're on geriatrics. But otherwise, urine dipstick, especially in AKI, can be really helpful. And the reason why is it tells you about whether there's any protein in the urine, any blood in the urine, any white cells, and any nitrites. So those are the 4 things that I'm really interested in with a urine dipstick and AKI. And there's a very general rule for exams. Really high protein on the urine dipstick would make you think of a nephrotic syndrome. So I'm not going to talk about nephrotic syndrome in loads of detail, but it essentially results in you becoming very edematous, your protein in your urine increases massively, you get frothy urine, and it's usually due to a breakdown in the glomerulus, allowing all that protein to just escape. You can also get it in vasculitis and things like protein in the urine. So that's one to sort of think about. High red cells, think of nephritic syndrome, so glomerulonephritis that causes blood in the urine, and often associated with hypertension. High white cells, usually an infection or inflammation. By obviously, white cells in your blood are associated with infection, inflammation. It's the same in the urine. And acute interstitial nephritis, which is a common cause of intrinsic AKI, will cause high white cells in the urine. So if you see that on a urine dipstick in an exam question, that's one to bear in the back of your mind. And then nitrites are indicative of infection, so UTI being the most likely. So if you had nitrites on a urine dipstick in this gentleman, I think that you might well have a UTI. But if the AKI, if they have an AKI and they've got a positive urine dip, then you should say to the examiner in the HOSCE in real life, which is probably, well, when you start work as a doctor in a few years, you need to make sure you send it to the lab for microscopy, culture, and sensitivity. Okay, so that's something to remember, because they can then look at the urine in more detail. And I don't want to over-labor the point of urine dipstick, but his urine dipstick shows that he's got dark urine. So yeah, he's got concentrated urine. There's nothing on the dipstick. It's boringly negative. There's nothing on there. So just one thing to sort of think about when you talk about urine dipsticks: when you have damage to the kidney itself, you're much more likely to have a positive urine dipstick in AKI, because it's the kidney itself that's causing problems, and therefore it'll produce cells in the urine. It will produce more protein in the urine because the kidney itself is breaking down or not working properly. Whereas a pre-renal, if they're dehydrated or they're not getting enough blood flow, then really the urine isn't going to contain anything different. There's just going to be less of it, or it's just going to be more concentrated. So that's something to think about. If you've got a normal urine dip, then you're much more likely to be a pre-renal AKI. And then obstructive, the only thing to sort of, might make you think of obstructive is you just have blood in the urine, like 1 or 2 plus of blood. Then that can be a sign of renal stones. So renal stones are an obstructive cause, and you often see blood in the urine. So that's sort of the only one for obstructive that's really interesting. So then blood gas. Now, I imagine that when people see us, they're probably like, can't be bothered to learn about blood gases this evening. So if there's an interest, then I'm happy to run a session on blood gases, or do a quick session in blood gases in the future, and certainly put that in feedback and feed that back to us if you would like a blood gas session, because I know as a medical student, they're one of the things that really got me. I don't understand, they're complicated, confusing, but it warrants a session on its own. All right, so I'm just going to skip over that and talk very briefly to say that you do a blood gas in AKI to check the acid-base statements of a patient. Okay, that's why we're doing a blood gas. And I mentioned at the beginning that kidney failure results in a failure to excrete acid and a failure to regulate bicarbonate. Okay, we've already talked about that. So in AKI, we're just checking for metabolic acidosis. So metabolic because it's the kidneys, and acidosis because we're looking at whether or not we can actually excrete the acid from the blood and get rid of it. So metabolic acidosis on a blood gas is a low pH, i.e. acidic, and a low bicarbonate. So a low bicarbonate and a low pH on a gas suggests a metabolic acidosis. That's all I want to say on the topic, because I know we can go down a rabbit hole of talking about blood gases, and I don't want to do that. And a blood gas in general for any patient who's unwell is useful. It gives you a lactate, gives you an anion gap, it gives you all the other things that we're not going to go over, but always think about suggesting a blood gas in an exam situation for a patient who's unwell. Okay, so a venous blood gas for Mr. N is normal, really. Well, his pH is normal. He's got a normal bicarbonate, a normal CO2, and his lactate is 3.5. So I'm not going to talk much about lactate because it's not really relevant to this talk, but a lactate of 3.5 suggests that his tissues may not be perfused, and there's lots of other reasons you can have a raised lactate. But generally, patients who are unwell have a raised lactate. So all fine? Well, not really, but that's all we can talk about for blood gas. There's not much on there that helps with the AKI. And a bladder scan. So this is the definition of an obstructive AKI as per me. Urine can't escape the kidney. So you get a bladder scan. I don't know if you've seen these on placement. I certainly haven't seen them until I was a doctor. I don't know how, but I managed to escape seeing them as a medical student. But bladder scanners are very useful tools to find out if there's loads of urine in the bladder. Doesn't replace actually pressing on a bladder and feeling a massive distended bladder. And certainly if you feel that on a patient, then you know they've got urine in their bladder. But you can use this ultrasound thing to find out how much fluid they've got. And it basically tells you if they're in retention. So it's an easy, quick, reversible cause of AKI. So don't miss it. Like, don't forget to just say that you do it, or on the wards, if you see a patient with AKI, that's something that you just don't want to forget about. And you can catheterize them and relieve the pressure. And if you just think about this diagram, you're thinking about the bladder becoming really distended and that back pressure going up into the kidneys. Relieve the pressure, relieve the AKI. And then finally, establish the diagnosis. So the kidneys have stopped working for a reason, right? So AKI is not the reason this man's in hospital. He's in hospital because he's unwell with an infection, more likely infection. And his AKI is what we found in his blood tests. They don't, he's not presented with a high creatinine. So we need to find out what's actually going on. So what do we think is causing Mr. N's AKI? You've already put it in the chat, but if anyone's got any other potential causes for his AKI that we've not talked about, there are others, there are definitely others. But you've already said sepsis, and that would be my sort of most likely. But if anyone's got any other ones, please put them in the chat. But this is what I've sort of condensed from what I've told you. He has a temperature, he has a productive cough, he has a low blood pressure and a high heart rate, a raised inflammatory markers, and he's got dark urine, he's dehydrated. So in my head, that suggests a man who has an infection, probably his chest, and he has a bit of a sort of septic response to that, and he's dehydrated as well. So sepsis causes vasodilation. So vasodilation drops your blood pressure. So sepsis isn't just dehydration, it's a vasodilatory response to infection. And that vasodilation reduces blood flow to the kidneys, as well as the fact that being unwell makes you dehydrated. So it's two sort of things really that's going on in sepsis. So CAP, so community-acquired pneumonia, would be my most likely differential. And unfortunately, having to mention the fact that he could also have COVID-19. Potentially less likely, given he's got a green sputum and he's got a low blood pressure. Because actually, most patients with COVID don't tend to have low blood pressure, at least initially. But certainly, I would not want to rule that out. So investigating further. So for pre-renal causes, it's pretty much find out what's going on and deal with it. So if he's got sepsis, you need to find the source. So you very, studiously already suggested the main ones, which are do some cultures, do a chest X-ray, and then you can also do a CT scan if you don't know where it's coming from and you're thinking maybe it's abdomen. You can also do an echocardiogram if you think it's infective endocarditis. So those are sort of the ones I would suggest doing for a patient with sepsis who you don't know where it's coming from. Hypovolemia. So if it's from bleeding, find the source of bleeding and replace, the bleeding with blood, which we'll come on to briefly. Dehydration. The way you find out whether someone's dehydrated is you examine them. There's no real shortcut there other than just to examine the patient. NSAIDs and ACE inhibitors, if that's causing the AKI, then you should just ask the patient what medications they take and check the drug charts and the GP records, and that will tell you. And renal artery stenosis, someone has actually suggested it, but you do an ultrasound Doppler of the kidneys to look at blood flow, and you do an angiogram and things like that. Now, you wouldn't do that immediately, and certainly I've never seen a patient with that, but that's what you would investigate in exams. That's what you suggest. You're basically looking at how much blood flow is actually going to the kidneys and looking at the blood vessels to the kidneys. An intrinsic AKI, how you investigate that? Well, you send your urine to the lab. You've probably got a positive urine dipstick in some forms. You send the urine to the lab and they look at it under a microscope. Check the CK, the creatinine kinase. Someone mentioned at the beginning about rhabdomyolysis, which is essentially a condition where your muscles break down. It's very straightforward in that sense. Your muscles are breaking down, usually because you've been on the floor for a long time and your muscles have just been sort of in one position and they've therefore broken down. A raised CK causes an intrinsic AKI. I won't go into the reasons why, but a raised CK leads to intrinsic AKI. So check the CK if you're not sure what's going on, and that if that's really high, that can be a reason. Vasculitis screen, something to look at if you're in time, if you're interested. Certainly, if you're interested in a career in nephrology or dermatology, then that's something to look at. But I wouldn't worry too much about that as a third-year medical student. Review the drug chart again. Lots of medications. I'm thinking of things like gentamicin being a classic example for exams. Causes an intrinsic AKI. And seek specialist advice if you think that someone's got an intrinsic AKI. And they sometimes do like renal biopsies and things. Admittedly, that is definitely not something to worry about in the short term. But and then obstructive, you'll see a theme here that the pre-renal obstructive causes are a lot easier to look for and investigate. A bladder scan and then a renal ultrasound. So you can look at the kidneys, and if they're really small, that suggests that there's probably some chronic problems with the kidneys. And also you look at the pelvis of the kidneys, the renal pelvis. If they're really dilated, that suggests there's an obstruction that you're not currently relieving, usually because of stones. But if you really suspect stones, then I covered this in my acute abdomen teaching a few weeks ago. There's a CT KUB, so CT kidneys, ureter, bladder, I think it's what it stands for. It's just a CT scan and it shows you whether they've got stones. So that's what you would do if you think that they might have renal stones. And they present usually with pain, loin to groin pain. We investigate this man further by doing a chest x-ray, as you suggested. And that shows some, well, it shows right basal consolidation, which the arrow, I didn't put the arrow on there, that was already on there. But that's what it shows, right basal consolidation. It turns out, we said he's on, got hypertension, but he's on ramipril. He's on 10 milligrams of ramipril in the morning. And he's been taking that even though he's not been feeling well. So with that in mind, let's take a breath. Where does that leave us? Well, his problem list. I think it's always helpful when you see patients, when you're clerking patients in, if you're in a situation where doctors said, oh, why don't you go speak to this patient? When you've spoken to the patient, you've been through the history, the examination, coming up with a problem list really helps. At least it helps me, and I think it helps most doctors formulate in their mind what's actually going on. And there's 4 things that I think are going on with this gentleman. He has a community-acquired pneumonia and a sepsis as a result of that. Okay, pretty straightforward. You see a lot of that in hospital. You certainly see that when you do medical replacements. He has a pre-renal AKI as a result of both of those, and the fact that he uses an ACE inhibitor. So the ACE inhibitor causes a constriction of the blood vessels to the kidney. So if you think about taking that while also not having as much blood flow to the kidney because you're unwell, that combination causes an AKI. There's less blood flowing to the kidney. And he also does have a mild hyperkalemia, which was on his blood tests. Not something to get particularly worried about, and will resolve if you treat his AKI, because his kidneys will then be able to actually filter out the potassium. So we've got 15 minutes left. So what are we actually going to do to treat this AKI? Well, we're going to treat the cause. Very straightforward. If you're asked how to treat an AKI, the correct answer is to treat the cause. Pre-renal, I've kind of already mentioned it. For infection sepsis, you're going to give source control. So that's a fancy way of saying treat the underlying infection. So if it's chest, then you can give antibiotics. If there's an abscess, you need to drain the abscess. If it's a fungal infection, then you give antifungal. That's the textbook answer, really. Also, give him some IV fluids. He's dehydrated anyway, and also he's a bit vasodilated. So when you're septic, when you're unwell, all the things that you release when you've got an infection that's causing a septic response leads to vasodilation. So if you give some fluids, you sort of fill that space a bit. It's not, there's a lot of controversy about fluids and sepsis. Not something to worry about, especially in medical school, but certainly you need to give them some fluids. And then patients who are really unwell will get vasopressors. So they're basically things that squeeze the blood vessels, and that will help the blood get to the kidneys. So if he was really unwell, that's certainly what he would get. If he's bleeding, you're going to stop the bleeding, and you're going to replace the volume with blood. not with fluids, with blood. If you're bleeding, you need blood. And dehydration, so fluid replacement, straightforward. Well, don't necessarily think that everyone who's dehydrated needs IV fluids. If you're thirsty right now because you've been sat listening to this revision session for too long, you're not going to give yourself a bag of IV fluids. You're going to go to the sink and get yourself a glass of water. So patients can often just drink water. So don't forget that when you're sort of suggesting in the exam how to replace someone's fluid. And drugs, well, stop them while they're unwell, stop the ACE inhibitors while they're unwell. And that's a really good one. If you're, I think on ward rounds and things, they might ask you about, what medications do we want to stop in this patient? ACE inhibitors are a classic, they're common and they cause an AKI. So they get stopped in anyone who's unwell. And then renal artery stenosis, well, you can, if you wanted to look up the management of renal artery stenosis, you can look at that in your own time. I wouldn't necessarily suggest doing so, but you may get a question on that in the progress test, I guess, but seems a bit unfair. But retention, well, catheterize, as I said, pretty straightforward. Don't need to do much else, but then you do need to find out why they're actually going into retention. That's not going to be covered here, but there are lots of reasons why people go into urinary retention. Renal stones, so they need to have the stone removed if it's causing an AKI. So usually that's through going through the ureter and fishing out the stone, or by decompressing by allowing the kidney to drain out through the skin. You will see that if you're on urology jobs or do urology placements. And other blockages, for whatever reason, basically just open up the blockage by stenting. That's not uncommon. And then the most fun of all, the intrinsic AKI. There's a lot of causes, and treating the cause usually involving specialists or seniors. So I don't think there's any point in really trying to worry about the ins and outs of managing all the patients who have intrinsic AKI. The most important things that you can do as a junior doctor and as a medical student, and you talk about it in exams, is know the basics. So ensure euvolemia. So by that I mean, if they're dehydrated, give them some fluid, because that will be contributing and that will make them worse. So make sure they've got enough fluid on board. Stop any drugs and toxins. So if they're on gentamicin, then stop that, because that may well be causing an intrinsic AKI. If you think they've got an inflammatory cause, then sometimes steroids are used. Basically, if you're not sure in an exam and you think they've got some sort of inflammatory autoimmune condition, steroids are always a good guess. They're usually the correct answer. And now with COVID as well, they're also for that as well. So can't go wrong with steroids. And the other option is watch and wait. So often these resolve on their own. And if you see these patients in hospital, often the renal doctors, and obviously having renal team at Salford makes it slightly easier, but they'll often just advise to watch and wait, and the patients do get better in time if you do those things. So a few classic exam intrinsic AKIs. Obviously take these with a grain of salt, they're not always going to be true, but young patients in exams and children who have lots of protein in their urine and they're edematous, they usually have minimal change disease, and you can treat that with steroids, so oral steroids. So that's a kind of classic, lots of protein in the urine, they're really edematous, minimal change disease. If you have a question where they have brown muddy casts in the urine and an AKI, so if they've got an AKI and brown muddy casts in the urine, it's usually acute tubular necrosis. So the brown muddy casts are basically, aspects of the kidney that have broken down and are being filtered out. So that's what you see. So to treat that, usually it's to stop the drugs and give some fluids. Obviously, there are more complicated management options, but that's basic. An AKI who has white cells, red cells, protein in the urine, so the urine dipstick lights up and they have an AKI, and the urine dipstick shows everything, then acute interstitial nephritis is often, I've not really seen many patients with it in real life, but in exams, it's a commonly asked topic. And in that case, you'd stop any drugs that might be causing it. And that's about it really from a sort of basic management. And then one that seems to come up in exams more than in real life is vasculitis. So the kind of cliched exam example is someone who presents with an AKI. They've also got hemoptysis or nasal congestion, or they're just generally unwell. nasal congestion being sort of a sign of, you can also have sinusitis and things. That's a classic for vasculitis. Now, if you see that in the exam, then it's vasculitis, but that's just one to bear in mind, really. And for progress tests or anything else, I don't think any OSCEs are going to revolve around vasculitis. So I've got 8 minutes left. Now I can use this 8 minutes to do various different things. My plan was to briefly talk about fluids and to briefly talk about dialysis, well, not dialysis, but questions about dialysis that come up on the wards. If anyone's got any questions, please put them in the chat and I'll answer them as I go through, because I'm conscious that finishing on time is important to everyone. So I'm just going to talk very briefly about IV fluids, a topic which, to be honest, until you start working as a doctor, I don't think you fully really understand, because you don't have to prescribe them all the time. But there are two types of fluid, and I apologize if you already know this, but it's important just to kind of get that concept. So it's colloids, and colloids are blood products. Okay, so giving someone a unit of red cells because they're bleeding, you're giving them a colloid. The other one that you'd see if you're on gastro placements, you'll definitely see is albumin, or human albumin solution, HAS. Now, those are the two that you will see for fluids that are colloids. There are others like starch and gelifuse, but they're just not used anymore, so you won't see them. So those are the two colloids. So if you kind of mentally just separate those two as being colloids, the rest of the fluids that you give patients are crystalloids. Okay, so pretty straightforward from that sort of. If you take those two out, everything else is crystalloid. And then, at least from Salford, I don't speak for the rest of the country, obviously, but I think it's pretty much the same. You have dextrose-based fluids. So those are essentially sterile water with dextrose in, usually. So dextrose being glucose, so sugary water. Then you've got 0.9% saline, or you can have 0.45% saline. That's essentially just sterile water with sodium chloride in. Often jokingly called pasta water by those who think it's a bit pointless, but yes, 0.9% saline. And then balanced solutions. So those are, at Salford is Plasma Light. So if you've been on placement at Salford, you'll have seen Plasma Light. The other options are things like lactated ringers and Hartmann's, which essentially are the same as Plasma Light, but don't contain, but contain lactate. For exam purposes are the same. So those actually try and match the physiological balance of fluid and electrolytes in your blood. So they're not just sodium and chloride, they contain potassium, they contain sodium chloride, but things like bicarbonate and all the other sort of electrolytes that your blood contains. So they're balanced, if that's the best way of describing them. They're the best, I think. I think at Salford anyway, most patients will get bags of Plasma Light, and certainly if you're resuscitating someone like this gentleman, my choice would be Plasma Light. I think most doctors would give Plasma Light just because it's the most physiological, but you could give 0.9% saline, especially in exams. You give that answer in exams. So for this gentleman, if it was me, I would, if he was an average weight, which we assume he's like 80 kilos, whatever, giving him a litre or 500 mils or a litre over 15 minutes, often described as STAT, 15 minutes, and assess his response. So by that I mean, does his blood pressure does his blood pressure improve and his heart rate settle with that fluid? The reason I say that is you can see these patients get a lot of fluid, and you will see these patients on the wards get given a lot of fluid. But I think just from an exam point of view and from a basic understanding, when you give someone a drug, and fluids are a drug, you should give them the drug and see how they respond. So I would suggest in this, if this is an exam situation and they were asking you what you would do for this patient, I think giving them a litre of fluid over 15 minutes would be reasonable and assess his response. 500 mils, assess his response, see if his blood pressure improves. And then a question which angry consultants is the wrong word, but consultants who maybe want to grill their medical students will potentially ask you, what are the indications for renal replacement therapy and AKI? So by renal replacement therapy, I don't want to confuse or go through things in too much depth here, but you can have dialysis, which is the one on the left, which is essentially involves, taking blood out from a fistula usually, or a line, and putting it through a dialysis machine, which separates or allows, by means of diffusion, removal of electrolytes and things from the blood and waste products from the blood, and then puts the blood back in without those waste products in. So that's dialysis. And then hemofiltration is if you do any ICU blocks, which I think you will probably later on, you'll see filtration, which is slightly different. It's kind of constantly filtering the blood, and works in a slightly different way. But either way, they're just removing toxins. All right, so that's all you need to remember, is you're removing toxins and balancing the electrolytes. So 4 ones for renal replacement AKI, which I guess is worth knowing anyway. So if you've got someone who's got a high potassium that doesn't improve with medical management, so basically no matter what you do, this person's kidneys are not removing potassium, and without removing the potassium, it just keeps going up in the blood. And high potassium, as you probably know, is really bad for your heart, and will lead to arrhythmias and death. So if you can't treat the hyperkalemia, then you need to take the potassium out using a machine. Similarly, if your kidneys aren't working to get rid of fluid, then you've got a likelihood of developing pulmonary edema, so fluid in the lungs. And if that doesn't get treated with furosemide or whatever other treatments you offer, medical management, then the only other way of getting rid of it is to filter it out using a machine. So that's a second reason why you'd put someone on dialysis. An acidosis, not something I think you'd see very often, but someone who's really not able to excrete any hydrogen ions or able to retain any bicarbonate, that can sometimes mean that they need to go on dialysis just to balance things out, because someone who's got a really bad acidosis, cells really don't like to work in an acidotic environment. So that would be why. And not as common as the other two, I think. But and the other one is a uremia. So when your urea goes incredibly high, so we're talking like 20s, 30s, 40s, I guess, you can develop an encephalopathy, which is basically urea goes to the brain, and the brain really doesn't like having loads of urea around it. So you become confused, you become drowsy, you develop sort of neurological symptoms. If you get that, then you need to get rid of the urea quickly, and the way you do that is by using a machine. I've never seen that. I think it's pretty rare these days because patients tend to present to healthcare before that happens. But you can also get pericarditis. Again, I wouldn't worry too much about that. But if you get loads of urea around your heart, it causes irritation. And not really an AKI indication, but one that I know consultants will maybe ask about is toxins. So if someone comes in with a lithium overdose, which is an example, potentially maybe more for 5th year, but lithium overdose, one way you can get rid of lithium is using dialysis. Not all medications and toxins can be excreted using dialysis, but certainly that's an indication. So it's exactly 7 o'clock. I have finished my talk. In summary, the kidneys, they're vital to homeostasis. If you take one thing away from tonight, I guess the best thing to take away is that the kidneys are really important to homeostasis, and when they go wrong, a number of problems ensue, which are all related to how the kidney works. So if you understand that, then you sort of got the basics you need for understanding what an AKI actually is. AKIs are bad, and in order to treat them, you need to find the underlying pathology, right? You don't just treat an AKI, you treat the cause of the AKI. And the best way to do that is to take a systematic approach. Okay, so take an approach that we've been through tonight, apply that in exam situations when you're on the wards, taking histories and things. Just think about what approach you would take, make it sure it's systematic. And in exams and in real life, there are a number of quick investigations that you can do or suggest to do in someone presenting with an AKI. So yes, you can do renal biopsies and ultrasounds and CTs, whatever, but you can do a few basic things that you can suggest to examiners, you can suggest to doctors on the ward, which are very, easy to do. You can dip someone's urine, you can do a VBG, you can scan their bladder, you can do a chest X-ray, you can do the basics. And those are the things I think, especially as medical students, you just need to remember. understand the common causes and the exam causes. I put exam because things like vasculitis occasionally come up, but they're not common. And how they should be managed. And often it's the simple stuff. So it's not just fluids. Admittedly, for dehydration and pre-renal causes, it often is a bit of fluid. But there are a few other things to remember, and drugs being one that I would definitely suggest that you think about, especially in exams. Review the drug chart. So I've put it on here, but actually, if you just want to put it on the chat, if you've got any questions, please do. It's on 7 o'clock, so I will not be offended if you leave. But the slides I will be putting on, or send an email out with the slides, and I'll put a video on YouTube as well. Yeah, if anyone's got any questions about kidneys in general, or about, I don't know, anything that they're kind of unsure about, please just put it in the chat and I'll answer it. I think next week, I don't know who's doing the talk next week, but I think there is a teaching session next week, and you'll get an email about that. And if you do know anyone who's not on the emailing list who wants to be, then please pass the message on, because obviously we're keen to get as many people coming to these sessions as possible. But thank you guys for coming. I hope you found it useful. And question, why is diarrhea a common symptom of UTI? So for anyone who's listening, and I've just had a question saying, why is diarrhea a common symptom of UTI? I wouldn't say it's the UTI is very overdiagnosed in hospital patients. So you'll see patients on the ward who have a UTI when they probably don't have a UTI, but that's just what they've been diagnosed with. But diarrhea, wouldn't have thought, isn't necessarily a common symptom, of UTI. But if you've generally got an infection, if you're unwell, patients often just get diarrhea because they're unwell. It's just one of these things, your body just decides that it's not working as well, and so they get a bit of diarrhea. If you're not feeling very well, you get diarrhea. Especially with COVID, actually, a lot of patients with COVID get diarrhea. The other thing is, it's not particularly pleasant, but if you've got elderly patients and they've got diarrhea, if you have all that fecal matter around the sort of groin area, and they're female, there's not much distance that fecal matter has to travel before it's sort of in the urinary tract, and then that's not going to do well. So that might be another reason, especially for elderly. Bit grim, I know, but certainly something to think about. That's an interesting question. Any other questions? Anything anyone else wants to ask? No worries. No worries. Thanks for coming, guys.